Welcome to another Viva Learning webinar. My name is Mary Gavoni, and I'll be your presenter for this program, Beyond the Pandemic. I know that we all want to put the pandemic behind us, but I also believe that we are forever changed and hopefully for the better by the pandemic because of things that we have learned over the course of the last couple of years. So first thing that I want to do is to thank our sponsor. And I need to get my slide advancer working here. Bear with me 1 second. Okay, now we're in business. So I want to thank our sponsor, Health First, who you probably know the best for your medical emergency kits that you use in your practice. I know all my years of dental assisting, we always relied on those amazing kits and the drugs in case we needed them. But Health First has introduced some new technology into the dental profession that we're going to talk about tonight. And it makes perfect sense as we talk about what do we do after the pandemic is over. And some people are, of course, hoping we return back to some state of normal, but I think it truly is. I know it sounds kind of cliche, but I think it truly is going to be a new type of normal. So this is what we're going to be discussing tonight. A brief update on the state of the pandemic. Where are we at? An update on CDC guidance, because there's been some changes recently about masking, and there's also been a lot of conflicting information about what applies to us in dentistry and what does not. So I'm going to hopefully clarify that for you all in this program. And then we're going to discuss a lot of the reasons why we should continue to be concerned about aerosols. There are other infectious diseases that are transmitted through the air beyond COVID-19 that we need to worry about so that we create a safer, healthier environment for us as dental professionals. So I'm going to start off this program with some good news. As of early last week, we got an announcement from the National Institute of Health that there are 3 mRNA vaccines that are now in clinical trial for HIV. We've been waiting 40 years to hear those words, that there's a vaccine in clinical trial. And this is maybe a silver lining from the COVID-19 pandemic, in that this mRNA technology that was used to create one of the, 2 of the COVID-19 vaccines was reported way back in the beginning of this research to develop the COVID-19 vaccine to possibly have application to other viral diseases. And so now we're seeing the benefit of that. There is a possibility as well that we may in the future even see a vaccine for hepatitis C. The big challenge with HIV and with hepatitis C has been that these viruses mutate so quickly and so readily that it's difficult to make a vaccine that's effective. And now we're seeing that even though the COVID-19 vaccine isn't perfect, we do have vaccine protection even against some of the new variants that have been coming out. And by the way, we heard today that 38% of the cases of COVID in the US now are the new subvariant BA2, and the other subvariant BA3 is spreading widely in China, widely in Europe, especially in the UK. And the belief is on the part of some public health officials that we may end up with yet another surge. Hopefully not, but we need to be prepared for that. So all the more reason why we need to talk about making sure that we're creating the safest environment for ourselves. So this is information from the CDC COVID tracker. Some of the links on your slides that you're seeing might be a little bit different than what I have, because I've condensed some of them down or shortened them because I think it looks better on the slide. So don't worry, they all go to the same place if you want to screenshot it and go to these sites. So the COVID-19 data tracker at the CDC is showing all downward trends for cases, deaths, hospitalizations, vaccinations at almost 82% for people over age 5. We heard yet today that Pfizer has announced that they believe the 2-dose smaller dose regimen for young children between 6 months and 5 years will be safe. And so hopefully we'll hear some more about approvals for that. But the total death number is the one that's alarming to me. Almost 1 million people have died now from COVID-19. And if you've been going back and researching the last major pandemic that we had globally, which was the influenza pandemic of 1917 and 1918, there were about 600,000 deaths. So we have now far surpassed that. Which is a scary, scary number. And to anyone who's experienced the loss of loved ones or friends, you have my complete and utter sympathy. I've lost some family members myself to COVID. So hopefully this will be over soon and we won't have to be talking about this anymore. Okay, so the new information that we've been hearing a lot about is the new metrics that the CDC is using now to advise communities about what to do, whether to mask or not to mask. And they use the term community level, and it goes from low to high. And it is based on some particular metrics that do not apply at this point in healthcare, but that's been sort of confusing. So the previous slide that I showed you was the community levels, which is based on the number of cases per 100,000 population and the number of cases that are, or number of hospitalizations and the number of inpatients that have COVID. This picture from the COVID data tracker shows the actual numbers of cases in the US as of today. So we still see some areas of the country that are in this darker blue that have 10,000 plus cases. But if you look at these two maps together, this map on the left for community levels looks very, very positive. Wow, most of the country's green. And you wouldn't think that we still had areas that had high number of COVID cases. So the difference, if you will, again, in how do we determine what we do in the public and in healthcare settings is based on the community levels. Remember, it's tied to hospitalizations, or in healthcare settings, it's community transmission, meaning how many cases are there? Because now what we're seeing with immunizations and better treatments for COVID-19, better availability for testing, we are seeing fewer hospitalizations. And even though the cases are not coming down, or they are, I should say, they are coming down, people are still getting COVID. They're just not being hospitalized for treatment, which is then considered to be a safer environment. But remember that dental practices are still healthcare settings and still considered a high-risk environment because we produce aerosols when we are treating our patients. So this is a more in-depth explanation of what the community levels are based on, those metrics for the low, medium, and high ratings. And we've been hearing, and I'm hearing from my clients that I work with, that their patients are calling them and saying, hey, we're all in the green area. Why do I have to wear a mask? Or they get to the office and they say, oh no, I'm in the green area. I don't have to wear a mask anymore. And so it's creating some uncomfortable situations for practices. You don't want to fight with the patients. You just don't even want to deal with COVID anymore, let alone have to keep explaining to patients. So here's what I would advise you to do. Inform your patients ahead of time, either through a text that you use, maybe through a software service where you confirm appointments, or if it's a phone call, you let your patients know, or you post information on social media or on your website that even though in our community, masking in public or indoor settings in the public is not recommended at this time, the mask mandates have been removed, masking is still required in healthcare settings because we use a different set of indicators as to whether we need to have you wear a mask. And we are a healthcare setting, so we can't forget that. So this is, again, is the criteria that the public sees. So if you're in an area of low community level, meaning, again, low hospitalizations, and you're up to date on your vaccines, meaning you have received all the initial doses and a booster, that's considered to be up to date, and you agree that, or you understand that you should get tested for COVID if you have symptoms, and you don't need to wear a mask, but you can still choose to. I still wear a mask when I go to the grocery store. I'm probably one of the few people when I go to church on Sunday that wears a face mask, but I'm concerned still about the spread. So if you are in an area of medium community level, then you, again, don't need to wear a mask. Stay up to date on your vaccines. However, you should wear a mask if for any reason you have some health concern, a severe illness, or you are immune compromised or immune suppressed. And then, of course, the mask requirement or the mask mandate still should be followed indoors in public if we have high community level, and there still are some areas of the country that do. So again, these do not apply to healthcare settings. These apply to public settings like stores, shopping centers, sports arenas, and so forth, not in healthcare settings. If you go into the hospitals right now, still required to wear a mask. You go into a medical practice, you're still required to wear a mask. But for some reason, we heard from a couple of dental organizations that we could drop those masking requirements if we were in that low community level. And that is not true at this point in time. Now, it could change. I'd love it to change, but it hasn't yet. So the CDC says that we should still follow the infection prevention and control recommendations for healthcare transmissions or for healthcare settings, and we should follow community transmission rates, meaning numbers of cases in our community to know whether we are at risk of being exposed or a patient coming in having COVID-19. The other things that we need to be aware of are things like the OSHA emergency temporary standard. Along with these masking mandates, most dental practices that I've talked to recently have made the assumption that they no longer need to screen patients either if they're in this low community setting level. CDC guidance still says screening patients. We'll take a look at that in a moment. And also the emergency temporary standard from OSHA still is being enforced in healthcare settings. And remember that you are exempt from that. And a lot of it is record keeping, nuisance record keeping, in my personal opinion, but you're exempt from that standard and those requirements if you follow the screening guidelines. If you're making sure that no one that's a patient or a visitor or an employee, a team member, comes into your practice with COVID symptoms, that you're not treating patients with COVID or COVID symptoms. And if you do all those things, then you are exempt from that standard. So again, we can't drop our guard at this point. Even though people are not getting as sick with COVID and the cases are starting to decline, the pandemic isn't over. So you still need to be asking those questions of patients. And yes, I know that people are tired of answering them. And I think the answer that we have to give them back is, the reason we continue to do this, dear patients, is to keep you safe, to create the safest environment for you, for your healthcare, and to keep ourselves safe so that we're able to continue to provide oral health care for you. So people don't question this like they do in dental offices. They go into a medical practice and somebody greets them at the front desk and says, "Sir, you need to wear a face mask while you're here." They will put one on. They don't question, but they certainly do in dentistry. And I believe, again, my personal opinion is that that's because we have let the inmates run the asylum for far too long, that we have let the patients make up the rules about payment, about treatment compliance, and about taking precautions for infection prevention. So we need to remind them. And so just like I think a lot of folks in dentistry did a really good job in the beginning of the pandemic, communicating with their patients about all the things we do to make dentistry safe, please come back. We need to remind them that we want you to stay with us. We don't want you to get sick here. We want you to keep coming back and maintaining your oral health. But in order to do that right now, we need to follow certain precautions. One of them is wearing a mask. One of them is we need you to let us know if you have any symptoms of COVID. So that's not fun and it's not sexy anymore. It just is what it is. And we just need to do that. And if it were me and I was the person having to deal with these questions all the time, I would certainly acknowledge the patient's objections. I know that you're tired of it. We're sort of tired of it too, but we need to keep everyone safe. Now, the other thing that I will tell you, and we're going to talk about this in a few minutes, is that it's not just COVID that we need to be screening patients for. And what has happened historically is patients would come in with a cold, with flu symptoms, and we would say, don't worry about it. We all wear masks. We're wearing gloves. It's no big deal. Come on in. And then, by the end of the week, everybody's sick. So I hope that that's going to be a paradigm shift for us, that we continue to screen patients for respiratory symptoms. Let them know when you confirm them. If you have any respiratory symptoms, let us please reschedule your appointment for you in order for you to be comfortable and for us to be safe. Because certainly influenza can spread, and we'll talk about some of the other infectious diseases that can spread. And why have those patients come in if they're potentially infectious when we can easily reschedule them? Now, I know there's some people out there that are probably saying, oh yeah, but what about production? You know what? You lose more production when everybody's out sick at the same time than you would by canceling a patient or two who have respiratory symptoms. So some people have said to me, well, gee, the OSHA temporary standard has expired. And parts of it have expired, but it is going to become a permanent standard. And OSHA stated back at the end of the year that they are going to continue to enforce the standard. So keep screening if you want to be exempt from the OSHA emergency temporary standard. This is, again, the set of guidelines from the CDC that we are required to follow. Now, some of you are saying, oh yeah, they're recommendations, they're just guidelines, we don't have to follow them. The reality is that pretty much all the states right now in the US incorporate CDC guidance either by reference, meaning they state in the dental rules from the dental board that CDC guidelines must be followed for infection control. Some outright state it as a specific part of the rule and say which sets of guidelines, like the 2003 guidelines or the 2016 summary of infection prevention practices. So I have been saying all through the pandemic and before the pandemic that don't get hung up on the musts and shoulds or the shall or the may or the recommendation versus mandate, because the CDC guidance and the CDC guidelines are the accepted, recognized standard of care. And so if you are not practicing to the current standard of care, then not only is that an ethical violation in a practice, it could also be a violation of your state Dental Practice Act. And that has far worse repercussions than simply having an OSHA citation for not following something. So I would encourage you all to make sure that you have the copy of this guidance. Remember that the CDC retired, if you will, the specific guidance for dental settings, and they incorporated it in to one set of infection prevention and control recommendations that covers all healthcare settings. But you can go through the document and find the information that pertains to dentistry. And here's again a reminder of what OSHA is saying, and especially about respiratory protection. This guidance from OSHA is what is being enforced by OSHA inspections, and it is based on community transmission. It is not based on community levels. Remember that low, medium, high related to hospitalizations. If there are still cases of COVID being transmitted in your community, this is what applies. And it depends on whether you're doing aerosol generating aerosol generating procedures or non-aerosol generating procedures. And what OSHA says is that if you are caring for patients where community transmission is continuing, no matter what the level, they're not putting a qualifier on it, and you're doing aerosol generating procedures, your eye protection should be goggles or a face shield, and your respiratory protection should be an NIOSH certified N95 respirators. The N word in dentistry, and I don't mean that to be offensive in any way. It's just that people don't like to think about or talk about N95 respirators. So OSHA's still sticking to that guidance at this point. And the CDC says two different things. One is source control, which means patients and employees should be wearing masks when they're in the non-clinical areas of a facility, so treatment rooms, okay? So patients come in, they sit in the reception room, they need to have a mask on. They can take it off in the treatment room, they put it back on when they leave the checkout and leave the practice. The team members need to be wearing their respiratory protection, N95 in the treatment room when they're doing aerosol generating procedures, but they can wear a regular face mask when they're outside of the treatment rooms. So again, make sure that you are not being misled by claims that you don't need to be masking anymore. And this information is pertaining to people whether they are vaccinated or not. Someone asked me a question yesterday. Well, if my patient says they're vaccinated, doesn't that mean they don't have to wear a mask when they come in? That is not true. Remember, even the vaccinated people out there in our population are still getting COVID and can transmit COVID. That was a big change from the, as they're called, the ancestral viral strains of COVID-19 to Delta and to Omicron. Delta and Omicron are able to be transmitted or spread so much more easily. Previous to those variants, people who were vaccinated were not considered to be infectious, even if they tested positive for COVID. They didn't have enough virus circulating to still be a spreader. But that changed with Delta, that changed with Omicron. And those are the prevalent variants right now. So vaccinated or not, they need to wear a mask. Now, some of you may still be wearing KN95s because you bought lots of them and you like them and they're less expensive than the N95s. However, this past summer, the emergency use authorization for KN95s was revoked. So what that means is they're no longer approved for use in healthcare settings. Excuse me. So you could use a KN95 for source control. So somebody in the business office or somebody who's not actually in the treatment room with aerosol generating procedures or doing aerosol generating procedures could wear a KN95, but you can't wear KN95s in conjunction with treatment. They are not NIOSH approved. And NIOSH, if you're not familiar, is the National Institute for Occupational Safety and Health. And they are the ones that test and approve or certify face masks and other items as well. You also cannot reuse respirators anymore. The emergency use authorization for decontamination of these disposable respirators, it has been revoked as well. So it's disposable N95s, no KN95s, although it's interesting, KN95s were promoted during the height of the Omicron surge for people in the general public to wear out in public in place of a cloth face mask, because cloth face masks were not considered to be as effective or effective at all in preventing the spread of Omicron. So the big question everybody has is, when do we go back to normal? And my opinion is maybe never. As I said at the beginning, I think we may be forever changed by what we've learned during the pandemic and what we ignored prior to the pandemic. So the answer is we don't know when the pandemic's going to be over. It being COVID-19 is probably never going away completely. You've probably heard or read that the belief is now that it will become endemic, which means that it will always be out there, but not at such high levels. That's very similar to influenza. It's endemic, it's always around, keeps mutating, and that's why we have to get a new flu shot every year. But the mRNA vaccine may also help to change that. So we just have to kind of wait and see what happens there. So let's look at what the old normal was and maybe what the new normal will be, and why is that so important? So pre-pandemic, if you can remember back that far, because it seems like it's like a previous life now, we didn't have a ton of concern for infectious aerosols in dentistry, unless perhaps somebody had tuberculosis or we suspected that they had tuberculosis. We didn't really seem to worry about, as I said before, if a patient said, you know, I've got a cold, I've got the flu, oh yeah, come on in. My favorite thing would be consulting in a practice, and a mom would or a dad would call and say, I can't send my son or daughter to school today because they have strep throat. Can I bring them in to have their teeth cleaned? And the answer to that, by the way, should be no. If they can't go to school, they shouldn't be coming and bringing that strep infection into the dental office. But the perception was on the part of team members and the patients or their families that, hey, we're all protected with all this personal protective equipment, so how bad can it be? Well, we have found out that especially the respiratory protection that we've been using really doesn't protect us that well from aerosols. Masks, as you well know, gap on the sides. Many times people were wearing an ASTM level 1 mask, which really isn't even rated to be used for aerosol generating procedures. And even if people did wear eyewear that was meant to be protective, sometimes they were prescription glasses, sometimes they were smaller safety glasses that still allow particles and aerosolized particles to get up underneath those glasses. And we know that COVID and other infectious diseases can be spread through exposure or contact with mucous membranes. And of course, the eye is a very vascular area lined with mucous membranes. So we certainly want to protect us. In fact, at one time, the CDC was recommending that not only did source control include wearing a face mask, but it included wearing eyewear all the time. And you do see the healthcare workers in hospitals treating COVID patients wearing those face shields. And they're wearing them all the time, not just when they're doing an aerosol induction kind of procedure. So that is a concern. We relied on PPE when we wore it correctly. I cannot tell you how many times I would go into a dental practice when I would be consulting and watch the hygienists using their ultrasonic scalers, and they had a face mask on, but it was down below their nose because they were too warm and they just didn't think about that. We put ourselves at some pretty good risk. We didn't universally use high volume evacuation. By that, I mean everyone who's generating aerosols. So the doctor assistant team would certainly use HVE, but hygiene historically used a saliva ejector. And we have some versions of saliva ejectors that now can be attached to an HVE line, but that doesn't make them an HVE device. They're still meant to control pooled fluids in the retromolar area. They're not meant to contain aerosols. And we very rarely worried about air purification. It's interesting. There's not as much methyl methacrylate being used in dentistry anymore, and not as much eugenol. But many of you, if you've been in dentistry for a fairly long time, remember that when you walked in the door of a dental office, the first thing you smelled was acrylic and eugenol, and maybe not necessarily in that order. And you also might be smelling a little form of Cresol if somebody was doing endo or if it was an endo practice. So there was a very distinct smell. Some of those products were emitting volatile organic compounds, which were never a good thing for us to be exposed to all the time. So it wasn't until COVID struck and us wanting to be back to work and back seeing patients that we really started putting in air purification in treatment rooms. And for those practices that are still using some acrylics and still using some eugenol, wow, it doesn't smell like a dental office anymore. And it's really interesting. I noticed a number of years ago that OSHA had really cracked down on nail salons because of the acrylics. So if you walked into a shopping center, an enclosed shopping center, whoa, it would just hit you in the face, no matter where that nail salon was. So OSHA said, no, 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 it's beyond the permissible exposure limit. And they made the nail salons install HEPA filtration in those facilities to control those odors and control those volatile organic compounds in the air. And now you walk into a shopping mall and you don't smell that anymore. So basically, the old environment wasn't as healthy as we maybe thought it was, even though we've never had high numbers of infectious disease outbreaks in dental practices that we know of, or that's documented, but still, that doesn't make it necessarily safe for us. One of the things we do know, there's plenty of research that documents the fact that there's a very high occurrence rate of asthma among dental professionals. Part of that is exposure to surface disinfectants when we used to spray all the time, but there may be other mitigating factors there. So the new normal, what we're evolving into now, has a heightened concern, a heightened awareness for infectious aerosols and air quality in general in dentistry. We're using respirators. We are probably going to, and you're not going to love hearing this, but we're probably going to continue to have to use respirators according to OSHA, even after the pandemic, because they view us in a high-risk category because of aerosol production. We have switched from safety glasses to face shields for the most part, or goggles. I don't recommend goggles to be worn because they're big and heavy, and they have a strap that goes around the back of your head, and it's kind of uncomfortable. But face shields, for the most part, are pretty comfortable, and they work. We are now transitioning into a more universal use of high volume evacuation in hygiene and in treatment operatories, restorative treatment, and of course, the use of air purification. This was one of the major recommendations that we got when we were given guidance to reopen practices after we were told to close down at the beginning of the pandemic. And many people went, out to the Home Depot type stores and bought HEPA filtration units to put in their practices without really knowing, did they meet requirements? Were they doing any good? Were they containing the infectious aerosols or not? We don't know. Now we know a little bit more about that. We're gonna talk about those. So I mentioned at the beginning that we need to look at other airborne infectious diseases, and this is what OSHA is looking at beyond the pandemic. Certainly on the top of our minds right now is SARS-CoV-2, but we did not have a major outbreak of SARS, the initial virus that seemed to stay primarily in China. Influenza is airborne, although there's some controversy if you read the research about whether it really is transmitted through aerosols or more through larger droplets and from touching our faces when they're contaminated with those larger droplets. But what about other coronaviruses? Colds certainly can be spread through airborne droplets. Chickenpox, measles. Measles can stay airborne. Aerosolized viral particles can stay airborne for up to 2 hours in a room after someone's been treated. We don't necessarily think of measles as a respiratory disease, but it is. It's a respiratory virus. And at the very beginning of the infectious disease process, the only sign of measles infection before they break out with a rash is perhaps runny nose, little cough, but the very first sign is actually in the oral cavity, in the buccal mucosa. Koplik spots, that's a great board question. Some of you may remember that. And if you see those lesions on the buccal mucosa, especially in a child that you're pretty sure has not had routine vaccines, they're already infectious. 2 to 3 days before they break out with a rash, they're already infectious. So then we look at mumps, pertussis, or better known as whooping cough, tuberculosis. Again, we've been concerned about that because, of course, in the early 1990s, we had a big resurgence of tuberculosis, patients with HIV co-infected with TB, diphtheria, meningitis, and this is not the entire list. These are ones that we would more likely be exposed to in a dental practice or from dental treatment. Sorry about that. My mouse is going crazy on me tonight. So I've included a number of resources here for you that I hope you will avail yourself of. The CDC's Center for Infection Control has a whole lot of information on modes of transmission for airborne disease and different research papers and things that have been conducted. One of the studies that I found in doing some research was that dental hygienists in a particular study were shown to have the highest influenza rates of any healthcare worker, possibly because of aerosol exposure. Just saying. So don't just take my word for it. Check out these resources and see if there's information that can help you understand the concern better about having better air quality in our dental practices. So this is an excerpt from that CDC page that I just showed you, and it talks about the spread of airborne infectious diseases as droplet nuclei, and those droplets contain potentially viable microorganisms. We don't know absolutely for sure that all the microorganisms are viable, but who wants to take the chance that they are? They may be protected by a coating of secretions. They may remain suspended indefinitely in the air. And everybody's been wanting to know, how long does COVID stay in the air? We know that it can stay suspended in the air for up to 3 hours, but is it still viable at that time? We don't necessarily know. I don't want to be a test subject and try to find out. We also know it can be transported over long distances. They've shown that some of the aerosols from COVID could be transmitted up to 26 feet, so almost 30 feet. So imagine how closely you work in proximity to your patients, and you're creating this soup of aerosol, and maybe you don't get COVID, maybe you don't get influenza regularly, but maybe you've just got a really super immune system. But do you really want to continue to put yourself and potentially your family at risk? So we know that there are health risks to dental teams, and we know there are health risks to patients from airborne particles. So here again are a few resources, research articles, documentation from OSHA that you can take a look at to help you, again, to have a more well-rounded, if you will, knowledge of what our risks are in dentistry. The first study that was done, I found particularly interesting. There are lots of good information about using HVE devices and so forth for controlling the aerosols. So we want to do as much as we can to control or contain the aerosols and prevent them from spreading throughout our facilities. Here's some more research on aerosols, specifically in dentistry. The second one, aerosols and splatter in dentistry, is one that was actually published back in 2004 by one of our beloved infection control experts in dentistry, Dr. John Molinari, and some of his colleagues. And this is making the case, of course, for using high volume evacuation, that you could contain the aerosol by as much as 90% by using high volume evacuation. But also, this research suggests a layered approach. It's not just about the suction. It's wearing PPE, certainly, and using high volume evacuation, but then going to another level, which is filtering the air in the treatment rooms or in the whole facility so that we have better air quality. And again, not just from microorganisms, we're using lots of chemical products all day long. And we have restorative materials that have silica in them, and we're polishing them and creating dust from that silica. So it's not just an infectious aerosol problem, but certainly the biggest risk we have right now with COVID and beyond COVID is the aerosol generating procedures that we perform. And this is how they are defined by both the CDC and OSHA. And you all know these. You've probably heard this in multiple lectures: high-speed handpiece, ultrasonic scaler, air water syringe, air polisher, air abrasion. Ultrasonic scalers being the biggest offender, meaning the biggest producers of aerosols, but there's also things you can do with an ultrasonic scaler to help minimize. You can turn down the water volume, you can turn down the power to minimize that, but there's still going to be some aerosol contamination in the air. So we mitigate the risks as best we can. PPE, which is not the first choice, for mitigating the risk. Mitigating the risk most effectively is that layering of engineering controls: high volume evacuation, enhancing our ventilation, and air purification. So the CDC recommendation has been that we should have at least 6, possibly 12 air exchanges per hour in an area or in a facility. And depending on where your practice facility is, you may not be able to achieve that if you have a very old HVAC system and maybe you don't own your building, you're a tenant and your landlord is not willing to update that system, which then makes air purification even more critical for you for good air quality. So this, again, is an excerpt from the Infection Prevention Interim Guidance from CDC, and it talks about engineering controls. This is the link on the bottom of the slide to this document. And there is another CDC set of guidelines which has to do with environmental infection control, and they talk about air exchanges and so forth. Some of it applies only to hospitals, but enough of it certainly applies to dentistry. And here is OSHA's definition, if you will, their recommendations about HVAC systems. So we want them to maintain the indoor temperature. Of course, we want you to be comfortable. And item C, of course, is one of the most important things. We want them to remove contaminated air, but your HVAC system may not be able to do all of that or enough of that. So here's some really good documents that I would encourage you to download from ASHRAE. This is the Society for Heating, Refrigeration, and Air Conditioning Engineers. And they produced this great white paper on air cleaner guidance for COVID. And they make recommendations about types of filtration systems and what are the minimum standards that you should look for in an air purification system. So these are free documents. You can follow the link, which probably looks different on your handout if you download the handout. And by the way, if you use the electronic version, meaning you download the PDF handout on your computer and view it on your computer. You should be able to just click on those links. So you shouldn't have to copy and paste any of the links. They should be live on your handout. So here are examples of air cleaning and purification systems. The two at the top that are underlined are ones that have been most commonly used in healthcare settings: ultraviolet light and HEPA. HEPA purification units or HEPA filtration units. There's a lot of information about these types of units, that how efficient they are, the size of particles that they can remove from the air and trap in the filters and all of that. The ones that have been researched the most in specifically in dentistry are ultraviolet light and HEPA. They are mostly passive systems. In other words, it's air in, air out. But now what we have are better options for what is a proactive system. And that is one that not only filters the air and filters out particles, but it produces hydrogen peroxide molecules that get dispersed into the air. And we know there's been lots of research that shows that hydrogen peroxide, it's the whole strategy or the whole theory behind fogging, that it can kill COVID and other airborne microorganisms. But fogging is something that is a one-time thing. If I fog my treatment room after I'm finished with a patient, okay, good, I may have killed everything in the air, but then the next patient comes in and I did an aerosol procedure, and now I've got airborne particles in the air again. So this system, which is called Active Pure, is one that is continuously producing these molecules so that it's constantly attacking airborne particles, and it's trapping other particles and volatile organic compounds in the room air through the filtration part of the system. So this is the next generation, developed for use on the space station. And that certainly is a very closed environment. It's not like you can open the windows up and, air out the facility. So there's lots of research behind it, lots of documentation that proves that this technology will work. So I put the link here for Health First, who is distributing this through Henry Schein. And there's some videos on their websites and lots of great information. You can download it. I'd encourage you to go look at this, because I think this is what takes us beyond the pandemic and into the future, and giving us really good air quality in our practices. And I don't know about you, but I want good indoor air quality. This month, I celebrated the 50th anniversary of my first day working in dentistry, 1972, which is probably way before many of you were even born. In the early days of my dental assisting career, we did not wear face masks. We did not wear gloves, but I sat chairside every day, all day, and breathed in all of those airborne particles. And I had upper respiratory infections all the time. I have some permanent scarring on my lungs from all of those cases of bronchitis and bronchial pneumonia and so forth. And so if I could go back in time, I would certainly want to wear respiratory protection, but I would certainly have wanted to have this kind of technology available to keep me healthier. What does it mean for me as I get older? I don't know, but I know it has made me more prone to upper respiratory infections, which is why I still wear my face mask when I'm out in public. So check it out. I highly recommend this for at least researching and see if it makes sense in your practice. So I hope that you've picked up some pearls in this program that you can use. And I certainly am open to questions. If you have any, we are going to take questions and answers in just a moment. But if you have questions that you didn't want to ask in the webinar, or you think about something later on, happy to do that. The best way to reach me is through email, mary@marygavoni.com. Put Viva in the subject line so I know where your question is coming from. I get hundreds of email every week that will, I attended your webinar, I attended your seminar, I'm like, oh, I don't know which one. I also put a QR code on this slide that you can use either from your handout or you can screenshot this, that goes to my website. One of the things that's come up a lot lately is the turnover of employees and practices. And we have lots and lots of new employees working in dentistry that have never had infection control or OSHA training. So what I've done is made my basic OSHA new employee training videos available to you at 50% off. If you use that QR code, it'll take you right to my website, to the store. And if that's helpful for you, great. I also would encourage you to go to a website, thecompliancedivas.com. These are three of my colleagues and myself that do a weekly compliance podcast. And we talk infection control, HIPAA, OSHA, all kinds of things. You can also use that QR code as well. And now we are going to move into questions, but thank you again to our sponsor, Health First, who brought this webinar to you. Okay, so our first question is, if an office requires a lab coat or full-length gowns over our scrubs, why must we change out of scrubs prior to leaving the office? Well, it may just simply be an office policy, but if you're wearing a lab coat that doesn't leave your scrubs open to contamination by aerosol, then you should be able to wear your scrubs out of the office. But is it the best idea? Maybe not. Maybe there is some potential contamination. But keep in mind that every dental practice can make their own policies about that, whether it's an OSHA requirement or not an OSHA requirement, as long as it's not illegal or immoral or discriminatory. It could just be an office policy, but there's not a good reason as long as everything's covered up. I think that I may have answered this question. Do the masks need to be N95 or KN95? KN95, again, is no longer approved for use in the treatment rooms, not approved for use in healthcare. Okay. Can you require proof of vaccination and booster before you treat patient and refuse to treat patients if they're not vaccinated? That is a really tricky question. You probably can, and I would actually talk to an attorney to find out the best answer for you, because some of it may depend on what are the rules in your state. Some states have vaccine mandates, some do not. If you do refuse treatment for a non-vaccinated patient and it's legal, just know that there may be some blowback to you, but you are certainly legally allowed to ask a patient if they're vaccinated or not. You are certainly legally allowed to ask them for proof of vaccination, unless there's some state statute that says you can't. But whether you want to refuse treatment or not is up to you. But keep in mind that even if they're vaccinated, it doesn't necessarily mean that they might not be infectious. And we don't make treatment decisions or whether we wear PPE or not based on whether that patient is vaccinated or not. Any updates on guidelines for nitrous tubing since COVID? You need to check with the manufacturer of your equipment. It depends on certainly the hood. The nasal hood must be either disposable, and I would only recommend disposable nasal hoods, not even reusable ones at this point. But the hoses might need to be replaced as well. It depends on where the valves are and the connections on your hoses on your particular unit. Crosstex, for one, has great disposable nasal hoods available in all kinds of sizes and smells and colors and all of that. I would not use reusable ones, COVID or afterward. What is your thought about possible decreased virulence of the newer variants of SARS-CoV-2? Well, what we're seeing right now is that these new variants of SARS-CoV-2 are as virulent, meaning they're spreading as easily or more easily. What they're not doing now, the difference is they're not causing such serious infection. So much so that some people think, well, my family member had COVID, they just kind of had some mild symptoms. So even though I now have some mild symptoms, I probably don't need to get tested. Anyone who has symptoms of COVID should get tested so that because you should be isolating. So you're not going to spread. Whether you're vaccinated or not, you can still spread it. Next question, any idea when or if the CDC will consider natural immunity in lieu of boosters? There's a lot of discussion about this. We don't know. In fact, we just heard, I think yesterday on the news, that Pfizer is possibly recommending a second booster for people 65 and over. So what we've seen so far is that natural immunity lasts for about 90 days. So after 90 days, according to what we know now, all bets are off. So it also depends on what we see with new variants. The more that the disease spreads, the more it will mutate. So we just really don't know yet. All right. Is it healthy for us to be in an environment with oxidizing molecules constantly in the air? Any studies on long-term effects of Active Pure? Yes, there are lots of long-term studies. Remember, this is the technology that's used on the space station. But I will refer you to Health First. Go to their website. They have all kinds of data, all kinds of studies. It is not, a lot of people asked me all during the pandemic, did I endorse fogging? Did I think that was a good idea? Well, as I said before, fogging, you're really creating a big mist, if you will, of whatever oxidizing molecules that were in the air. And so that could potentially be hazardous because of volume. We're not talking fog. We're not talking clouds of mist. So again, I would refer you to Health First because yes, there are a lot of studies. Next question, can we wear long lab coats now, or do we still have to wear surgical gowns? That is a really great question. And it really depends on the kind of procedures that you're doing. That if you are doing procedures where there's high volume of aerosol, like ultrasonic scaling, I would probably wear a gown that has a higher fluid resistance rating than a lab coat would. But it depends on the type of practice that you have. So I hope that helps. Let's see. Oh, thank you for the congrats on 50 years. That's actually a scary number to me. I'm allergic to our disposable N95 masks. Is there an alternative? Well, there are different manufacturers and different brands. And I would say, Are you truly allergic? I mean, have you been tested by an allergist to document that you are allergic to them? Or is there something in the mask that's irritating to you? So I think I would certainly try another brand, and I would validate that it truly is an allergy. Some people have developed, they called it maskne, where people get rash on their faces. That really isn't an allergy. It has to do with being warm and so forth. Oh, thank you for the feedback on the presentation. I would slaughter your name if I said it, so thank you for your feedback. What would you say to the only hygienist in her office who uses HVE, N95, face shield, and surgical gowns? I am feeling very torn. I'm assuming that, well, I guess I would congratulate them. I'm not exactly sure how to answer this, that if they're doing all those things, they're doing the right thing. And it is, as somebody just said, the gold standard. So I don't know if you're torn about because you think that they're overdoing, they're overkill. I'm not really sure how to answer that question. So maybe you could clarify that just a little bit for me, Denise. What should you do if your office wants you to reuse an N95 for 5 days? What I would do is point out to the doctor and to the safety manager that that reuse guidance has been revoked. There's certainly a risk to you for reusing it for 90 days. Remember, or 5 days. The only reason we did was because we couldn't get them. That didn't mean it was safer for us to reuse them for 5 days, because after a period of time, they decrease in effectiveness. What about small fans in a room to keep you cool? Fans in a room are a no-no, because what they do is spread the aerosols outside the room. So no fans in the room. You could possibly use a fan that you aimed out the window, or a window mounted fan, to take air out, but not that it's blowing on you or blowing around the office. Do you feel as healthcare professionals that we have an ethical responsibility to get vaccinated to protect ourselves or protect our patients, especially the immunocompromised? Yes, I do. That is my personal opinion, that I think we have an ethical responsibility to be vaccinated. I believe that we have an ethical responsibility to practice the highest level of infection control and safety that we can. But I also understand that some people have religious beliefs that prevent them from being vaccinated, or they have medical reasons for not. The rest is, in my opinion, political. And that's all I'm going to say about it. But I do believe we have an ethical responsibility. Do rotary style polishing motors create aerosols? Slow speed handpieces are not listed as aerosol generating procedures. Those slow speed handpieces or polishing motors create spatter and splatter, which still can be infectious. So you still want to wear your PPE, but do you need to use high volume evacuation when you're polishing? Probably not. Okay. Bev, yay for you. Dental assistant became a dentist. Good for you. If I wear reading glasses with a face shield, do I still need to wear more eye protection like goggles? No, you do not. So if you have a chin length face shield with your respirator underneath, and you wear the reading glasses or loupes for that matter, no, you don't need to wear more eye protection. The whole purpose of the face shield, again, is to prevent the aerosols, which are coming, or the spatter, which comes almost directly at your face, rather than down by where your chin is, from getting up underneath and getting into your eyes. Okay, so I am not seeing any more questions. We'll kind of make the last call for questions. But again, if I can help you with some support documentation, or maybe some of the links don't work or something and you need information, please email me. Again, put Viva in the subject line so I have an idea which webinar, and maybe put Viva 323 so I know which webinar it is. So I thank you again for your participation, and we're going to turn it over for instructions about getting your CE credit.